Once we have accomplished all that, then we can get into what is the fun part, which is that advanced strengthening phase. So we want to make sure that the VMO and the vastus lateralis have an appropriate ratio. So like I talked about, the outside structures can get really tight, causing the patella to track outside and laterally. So we want to make sure that our medial structures are really strong before we progress to this phase. With this, we can get into squatting, we can get into lunging, and there's actually evidence that shows that to actually strengthen the VMO, and about 60 degrees of knee flexion in closed kinetic chain will help with assist in strengthening this. So adding a ball, doing anything in adduction will help with this. Then we get into the fun part. So all the plyometrics, we can add hopping, we can add squatting, we can do box jumps, we can do lateral stuff, anything to get into that multi-directional movement. However, like I talked about, it's important to have that hip control. So we don't want to progress a patient too fast if we're noticing that they have impaired biomechanics. So we want to make sure that we're progressing them appropriately. Then lastly, my second probably fave is to get into the sports stuff. So looking at what our athlete is returning to, whether it's a team sport and they need to do high agility, that multi-directional, that lateral shuffling, jumping, or is it looking into how they're landing? So if it's a gymnast, personally, then I'm looking at how they're landing, how their squatting biomechanics are when they take off, as well as soon as they do whichever move they need to in the air, and then how they're landing out of that, or landing off a beam, or doing any type of activities. It's looking at that. So adding in different activities that include how looking at the proper landing biomechanics is super important. It's also important to look at single leg stance. So not only how the athlete is landing, but like my gymnast, she does a lot of beam work. So looking at how her single leg stance, is she having still the proper biomechanics, but still on that leg that she subluxed in? So can she be able to perform turns? Can she be able to perform all the twists and turns that she needs to do to be able to perform her beam, her floor routine, and whether it's bars, looking at all of that as a whole. So it's very important to look at everything, but also break it down and make sure you're progressing them appropriately. So once we start thinking that our athlete is ready to return to sport, there's actually a criteria that will help us to guide us in our decision making. First, we're going to make sure there's an absence of pain. Second, making sure there's no joint effusion. Third, they have full range of motion. Fourth, that they have almost symmetrical strength, meaning they have at least 85 to 90% strength on the uninvolved side as they do compared to the involved side. And then lastly, we want to make sure that they have good dynamic stability. However, it is important to consider this could take anywhere between 6 weeks up to 6 months. So it's important that we're progressing our patient appropriately. Next, it's looking at how we can test them. The single leg squat and the STAR excursion balance test will look at dynamic stability. The drop jump test will look at symmetry and their alignment when they are landing. And then the side hop test will look at speed, agility, and coordination. For all of this to be successful, we want to make sure this implies there's no early re-injury, there's no further damage to the knee, they're returning to at least pre-injury level or better, they're not limited by pain, and they are playing at the same level within at least 5 years. So should your patient have surgery? Generally, if they're a first-time dislocator, they will benefit from rehab. However, if this is their second time or multiple times dislocating, they will benefit from surgery. In surgery, they will go in and they will actually tighten the MPFL and release the lateral structures. However, when comparing non-operative groups to operative groups, they have similar results in terms of instability, but when looking at likelihood to redislocate, the operative group had about a 10% decrease in likelihood that they were going to redislocate. But when comparing functional outcome measures, the non-operative group had improvements overall in quality of life and overall patient satisfaction. When considering if a patient is a good candidate for surgery, it's important to look at if they are an adolescent. If they are, it's important to look at the age of them and their growth plates. So if a patient has severe trochlear dysplasia, meaning that there's abnormalities in how the trochlear groove and the patella are functioning, then they will go in and they will actually make the trochlear groove appropriate positioning for the patella to fit appropriately. Sometimes a common thing is that they will have a shallow trochlear groove, which will predispose them to tracking laterally just due to their anatomical position, which predisposes them to subluxing or dislocating. So they will generally do this if a patient is expected to stop growing within at least 2 years. However, it's important to look at the patient as a whole, looking at what they're trying to get back to and the likelihood of them redislocating when considering this. I really hoped all of that helped. I actually have a blog linked to this as well. This is just a little snippet that I put in my blog, but basically I chose this topic because I've actually seen a decent amount of patellar dislocations. And I have to say, just in general as a physical therapist, so one of the hardest decisions to make is returning an athlete back to sport. It gets to be really scary because of the fact that you can rehab them as much as you want, you can challenge them as much as you want, but it gets down to the point of assimilating those activities and what they can tolerate and getting them back into practice and knowing in your gut that you've done everything that you can, and that they can tolerate what they're doing in practice, and then not knowing the other stuff that they're also doing. Like, you can get a glimpse of what they say they were doing in practice, but then they could be doing extra stuff that they didn't think was important. So it's really knowing what they can tolerate, returning them to full practice, but also keeping in mind of your own head, so to speak, in terms of like when they have nationals, when they have competitions, like really understand and trust your knowledge and trust your gut in how you're progressing them. Because I will say it is one of the hardest things when they say, I want to be able to compete in this competition within a month, and they just recently dislocated their patella. They can't get their full range of motion. They don't have the strength. They're not progressing on how you should. Like, do they need surgery? There's all these other confounding factors that go into your head, and it's hard to know, like, am I progressing them? Am I doing everything that I possibly can? So I really wanted to dive in and look at this and being able to know that what I'm doing for my patients is appropriate. And, if it means that they can't compete now, it could help them, because then they could just be a stronger competitor next year if that's what it takes. So I really hope this helps shed some light to other PTs and to help others understand. And I hope you guys enjoyed.